Now we will go for the part B. What is the 6-step clinical thinking algorithm? What is the benefit of this part? Actually, as a pharmacist, when someone wanted to ask me about medication, this question I can face in the hospital setting from anyone from the healthcare team. If I work as a clinical pharmacist and participate in a round with a other healthcare team like physician, nutritional consultant, nurse, whatever, then they are discussing the case and we will know, inshallah, later on details how the clinical round going on the hospital. And this is also a very important information in any interview if you want to apply as a clinical pharmacist. So in the clinical round, they are discussing the case and also discussion of cases in the pharmacy student on the level of pharmacy student. It is important also while they are representing or they are studying the case, how to study it, how to represent the case in front of the physician. That's also an important point. And both of the scenario and the other scenario had the same answer, had the same sequence, which I will explain now. When you face this question, what do you think about the medication plan of this patient? How you will arrange your answer? This is a difference also, one of the major difference between the highly qualified professional pharmacist and the others. First one, I need to have put in my mind 6 points. First point, indication. What this patient have. Why I prescribe this medication? Is the diagnosis confirmed? And if the diagnosis confirmed, is this medication is a first line their current guideline? I will ask here one question. Patient has an infection, like for example in the hospital we can say uh, kind of cellulitis. Cellulitis means some skin infection, superficial skin infection. And I found in the clinical round that the doctor prescribed for him meropenem. My question, is the meropenem as antimicrobial or antibiotic suitable for this patient? First, it will cure cellulitis or no? I'm waiting answer. Do you know do you know carbapenem, meropenem or imipenem? Do you remember? الصوت ما في صوت. Screen now clear.
لأ لسه.
طيب. Now we talk about, if you got this question, what question? What do you think about medication management? Where I will face this question? You will face it in the student as a student level of the university. For example, if you have some cases you need to discuss, or you have like presentation, like master program, whatever. Then you have a case and you need to represent. First, you need to understand this case and to present in a professional way in front of your team of professors. Or if you be like graduated and you start in your market to search for your career, even in community pharmacist in the hospital, inpatient or clinical pharmacist, and you are participating clinical round, you are in between a healthcare team like physician, consultant, MRP, nurse, nutrition, whatever. And when they will started discussing about the medication, as we said that you are the only drug expert, so they will ask you as a pharmacist, doctor, please, can you tell us what do you think about the medication plan of this patient? Before I answer, it must be 6 points clear in my mind. First point, indication. Why I need to give this patient this medication? Diagnosed, is it confirmed? And if diagnosis confirmed, is it the first line per current guideline? Here I have a question for you. Do you know imipenem and meropenem, carbapenem group as antibiotic? Do you still remember?
دكتور ممكن تعيد؟
اوكي. آه، اعيد من اول فين؟
فممكن بس حضرتك تعيد السؤال، ما سمعتش.
اوكي. Do you remember the carbapenem like imipenem group, imipenem and meropenem as an antibiotic, carbapenem group.
أيوه.
تمام. If the patient admitted to the hospital with like cellulitis mean infection of the superficial skin، عنده شيء في السكن زي جرح او شيء، ولكنه هو يعني وايد سبريد، فعشان كده اضطر ان هو عنده فيفر و admitted to the hospital. My question, doctor prescribed for him meropenem. If meropenem proper, it will cure this patient.
Meropenem is mainly indicated for gram-negative bacteria, right?
Meropenem is one of more wide spectrum, gram negative plus gram positive also. It will cover both. Most of microorganism covered by meropenem. So it is why called from widespread antibiotic.
But we can't start with it because we need to reserve it for
Yes, exactly. This is
يعني
the
the
answer.
last
Yes.
line.
This is the answer which I want to hear. Dr. Fatma, if I ask it, why we can't start if already this first question I answered. Why carbapenem? Because the patient got infected and I need antibiotic. Okay. Diagnose confirmed? Yes, confirmed. Is it the first line? Dr. Salma said no. This is not the first line. What's your opinion? Why we can't start with meropenem for this patient? If it is cured, already he will cure the patient. Why I can't start?
Because we need to follow the guideline.
Excellent. And what will happen if I start with wide spectrum antibiotic for this patient?
Resistant
Yes, yes,
bacteria.
exactly, resistance. Do you know this is one of the main interview question if you apply as infectious pharmacist? And this is the core principle of something called antimicrobial stewardship. This is what we will take inshallah later. The core principle, what you told me now in simple sentence, because of resistance. Because of resistance, the guideline all over the world make like program is antimicrobial stewardship. Because of resistance, it is a criminal for any pharmacist or anyone in the community pharmacist prescribe antibiotic for the patient without the physician recommendation. Because of the resistance, we found now some microorganism and the people died with it because most of antibiotics that these microorganisms this resistant already for it. So this is simple information. If I know in practice, you know how it make a large difference. Second one, guideline alignment. This is what you told now. What what does evidence say? American, if I want to treat cardiac patient, I need to go for American cardiology or American Heart Association. If I want to infectious patient has infected, I need to follow up ITSA. ITSA, this is guideline of infectious disease. If I want to treat renal patient, I need to follow KDIGO guideline. If I need to treat diabetic patient, I need to go for American Diabetic Association. And also ESC, this is for also cardiac, as I think, yes, cardiology also. If I want for grad system, if I have patient admitted because of myocardial infarction and I need to take the decision as a cardiologist, this patient need I make intervention like BCI اركب له دعامة ولا لا, according to grade system. And I need to know something called absolute risk reduction, relative risk reduction. If I'm working in the research, these three terms, ARR and RRR and the number needed to treat, this all I need to is principle I need to know. But in our clinical practice, these last three is not much important. What I need to know from this point, guideline alignment, to be sure as a pharmacist when I take decision to say yes, keep this patient on this medication, or no, please stop this medication, I will not talk from my personal opinion. I need to have a clear guideline to follow. Third one, mechanism. Do you think anyone in the healthcare team know about the mechanism except the pharmacist? Mechanism of medication, how it worked inside the body. Anyone in the healthcare team know about this except pharmacist?
No.
No, right, no. And this is one which make us drug expert. How does this medication hit the target? What is the receptor? What is the enzyme class? What is the meaning of agonist and antagonist? What is the Emax EC50 as we take? Patient specific pharmacokinetic. Why I can give the patient with renal issue vancomycin? I can't give vancomycin, or even if I need to give, I need to reduce the dose. Patient with hepatic and this medication metabolized by liver, so I need to reduce the dose. What patient is obese, I will not give him the same dose of the patient which is not obese. Patient has low albumin, patient is in ICU, so patient specific. What is the risk of this medication? And I need to tell you from my experience. Also, the physician doesn't know anything or know very low information about the adverse drug reaction, about the drug-drug interaction. If you worked in a community pharmacy, or inshallah if you joined any hospital, you will find a horrible number of drug interaction. The physician doesn't notice even about it, and and of course the nurse will not notice it. So you are the only one who protect the patient and improve patient safety by knowing this interaction. Even this interaction can happen in the real world outside the hospital. Like for example, patient is taking warfarin, and after taking warfarin has many drug interaction. Not only drug interaction, has many also drug food interaction. If the patient, for example, eating like green leaves a lot, green leaves have full of vitamin K, and you know that vitamin K antagonist the action of warfarin. Okay, so this interaction, actually this also science for pharmacist alone. And monitoring plan, after we giving the medication for our patient, how we monitor. For example, if I giving vancomycin, how I measure the vancomycin level, the trough level. If I giving, for example, beta blocker, how I measure the heart rate, how I measure the blood pressure. So these 6 points, if I memorize, I can read any case, I can represent it, I can be in confidential way answer any question in the hospital setting or outside about, do you need to give this medication, this patient this medication or no. Our last part for today, like absorption and uh, bioavailability, this pharmaco, which is called pharmacodynamic. What is our body do in our medication? What is the absorption? What is the distribution? What is the metabolism? What is the elimination? These actually we took in the university as a theoretical information, but we didn't realize or we didn't think that we can use it. I can tell you, in the hospital, most of medication management from the pharmacy depend on these basic information, which you see like you was maybe you will feel bored while studying, but this is very important in the practice. I need to know what is the meaning of absorption and bioavailability. And we will take this our last slide, not to make it too much huge for you. This, I want to know something called bioavailability. Do you know in a simple way what is the meaning of bioavailability?
Uh, like
Hmm,
how much of the drug will be absorbed.
excellent, doctor. Yes. طيب, doctor, other question. Why it is important to know how much of the drug will be absorbed? Why this is something important for me as a pharmacist?
To know how much the concentration in the body.
Yes. And sorry, what is the important point in to know how much concentration?
To not reach the toxic level.
Not reach the toxic level. This is one point. What is the other point?
Therapeutic level also.
Yes, yes, exactly. Therapeutic. To be sure that this medication it will be effective for this patient. Otherwise, it is useless. I giving the patient side effect without benefit. You know this simple information how you can apply in practice. For example, if I ask Dr. Salma, why the patient in seizure or in severe pain or in severe case in general, I prefer the IV medication, not oral medication. If even if he can taking the oral and he tolerated to oral, why I prefer IV? With to know that IV has many complications, by the way. Why I prefer IV in urgent severe cases than oral?
Because we need faster onset of action, so we need
Yes, yes,
to give the drug
yes. And this
to
onset of
the
action
bloodstream
depend.
directly.
Yes, this onset of action depend on what, doctor?
Depends on bioavailability. The IV
Bioavailability.
bioavailability is about
Yes, yes.
100%.
100%. Yes. This simple information can give you like priority higher level than any health cares when you see the urgent case and doctor prescribe. For example, some antihypertensive urgency, and we will take, inshallah, we can in cardiac medication. We will know what is the difference between hypertensive urgency and hypertensive emergency. Both of them, it is from hypertensive crisis. Hypertensive crisis means a patient with blood pressure more than 160, okay, and sometimes more than 180 as a systolic, over 120. So in this in hypertensive crisis, the patient should be admitted, must admitted. But in urgency, I can give oral medication, but in emergency, I must give IV medication. Because of what? Because in emergency means what? Means that this blood pressure, higher blood pressure, causing a severe damage for the patient. He caused like AKI, acute kidney injury, or he caused for me stroke, or he caused like bleeding, or whatever, eclampsia, pre-eclampsia. Something happened, a change happened in the physiological process inside the patient because of this high blood pressure. Because of this, I need to know that IV, I must start with IV. But in urgency, yes, I have a very severe blood pressure high, but I can use oral, normal. No need for IV because I don't want fast action. But in emergency, I need fast action. So by this information to know that IV 100%. Also from IV to IM. IV, this is my best route for emergency cases. IM, this is the second one. the F means bioavailability. Bioavailability, it will be 75 to 100%. Subcutaneous, okay, 75 to 100%. Oral, I have from 5 to 100%. For example, morphine. If I give morphine as oral for pain management, I will get only 20 to 40% from the medication will be absorbed. So the oral dose to give me effect, it must be 3 double the IV dose. And this information for pharmacist only. When I see order of morphine with same dose of IV, I will call the physician, doctor, please note that the bioavailability of morphine from 20 to 40%. So your dose of IV should be doubled by 3 times of oral if you want the same effect of IV. See how you can use your knowledge in practice. Also, propranolol from 25 to 30 to 40% as oral. Lidocaine 30% only, so lidocaine not given orally. Nitroglycerin, bioavailability less than 1% oral. You know what is the use of nitroglycerin?
For the angina.
Angina, yes. And have you ever seen in your practice or in your knowledge someone has angina or MI taking nitroglycerin by oral?
No, only sublingual or as
Sublingual.
patches.
Yes, sublingual. Why sublingual? Because if he swallowed as any other tablet, it is useless. See, less than 1% bioavailability. So it will not, he will die. He will not get benefit from this. So, but sublingual route of administration, it will give me the needed onset of action or needed bioavailability. So according to bioavailability, I can improve the patient safety if I know it for each medication. Sublingual, it is high bioavailability and onset. And we know that onset, of course, I will not go for this. You know this better than me. Onset means how many time of the medication to give me the maximum effect or start effect of the medication. IV gold standard, irreversible, of course. So I need to be careful because some medication, and we will take this later. Some medication has irreversible damage if it is taking IV. IM because of depot preparation possible. Subcutaneous as we used in low molecular weight heparin. And also insulin. We are using insulin and anticoagulant like heparin, like enoxaparin, low molecular weight heparin, subcutaneous. Oral, this is the safest route, but it must cross the liver metabolism first pass, and it's affected by food. Some medication shouldn't be taken on empty stomach. Some medication shouldn't be taken with food. Sublingual, also like nitroglycerin, as we said. Inhalation, this is for asthma or COPD. Transdermal like fentanyl patch or nicotine. Okay, and the last one like rectal. Okay, this avoid some first pass, and in rectal I will get by availability 50%. Like in some kind of seizure in the hospital, the first, you know that the first line of management of pediatric seizure to give rectal like rectal diazepam. And this we will inshallah we will discuss it while we talk about the psychiatric medication and the anti-seizure neuro medication. We will see what is the difference in bioavailability, how we apply this in practice, especially to manage like condition like seizure. So from our lecture we talk like some simple information as standard, as basics, but while we will discuss each group of medication, we will go deeply. Each medication, what I need to know exactly about it and how to apply this information simply in the practice to improve myself as a personal professional pharmacist, and also to protect the surrounding people, even within not only in the work field but also in the normal life, like my family, my friends, my neighbors, whatever. I can be useful for them. From some simple information I can change their life or protect them from irreversible harmful uh, can never be cured later on. So I hope that you enjoyed the lecture, and inshallah we will arrange the next meeting. I will share the the link